Hello everyone, a very good afternoon. Today we are going to talk about the most exciting topic in echo, which is aortic stenosis. I apologize for the delayed onset, I should say, but we'll make the lecture, late peaking, a top-notch lecture today. Sadly, I don't have any disclosures. For our favorite Twitter handles, don't forget, and for our viewers on live stream, please subscribe and follow DeBakey Institute for Cardiovascular Education and Training for current updates in cardiovascular medicine. And a special thanks to Dr. Zogby and Dr. Faza for some of the slides. And yes, we are going to base our discussion based on our ASC guidelines, right? So both the valvular stenosis guidelines from 2009 and the more updated 2017 guidelines, which actually delve more into the details of aortic stenosis specifically, and also about challenges in multimodality assessment of aortic stenosis. Our outline is going to be quickly a review of anatomy and causes, and mainly the focus is going to be assessing the indices of severity and also grading aortic stenosis. And again, a little bit about management, although due to interest of time, we'll keep it more focused on echo. I am an echo and Jeopardy enthusiast, so I did have to include a slide on that. So any takers on this? I think I got the answer, right. So aortic stenosis with intestinal angiodysplasia and acquired von Willebrand syndrome, which is Hyde syndrome. Just one more, I promise. What is the aortic valve area? And if you're asking me if the aortic pressure is 121, yes, it is 121.
So it's going to be 170 minus 121 over square root of 7.
Oh, almost there. Right? So it's basically cardiac output divided by peak, LV and aortic gradient. And that's why I put 49 on purpose, so it's easier for calculation. In fact, Dr. Haki was a cardiology fellow in 1981. He was so tired of using Garland that he wanted to find something simplified. And it actually has pretty strong correlation to Garland, except for extreme heart rates. All right, let's move on to a quick recap of our aortic valve anatomy. I'm sure all of you know that we basically named the three cusps after the origin of the coronary arteries, which is the right, left, and non-coronary cusps. Obviously, there are variants which are, bicuspid, unicuspid, and quadricuspid. And if you look, obviously there are two major types, right? So the degenerative calcific type of aortic stenosis, which is, as you see, it's calcification through the cuspal edges, progressively causing narrowing of the orifice, versus rheumatic aortic stenosis is characterized by commissural fusion, seen predominantly in the younger population and middle-aged adults. And as you see, it's basically the commissural fusion and thickening which causes progressive narrowing. And again, a quick note, I'm sure all of you here have seen at least one case of this, which is nothing but prominent nodules over anti, which are the cuspal insertion points of the aortic valve chordae. Again, usually benign variants, but there are some variants, again, in real life, sometimes you're not totally sure, so you might have to do TE to confirm it. Again, these are just, benign variants most of the time, although there are rare cases where there's thickening and calcification causing tenting of the leaflets can cause aortic insufficiency. And this again, one mention, I'm sure every one of us have seen this as well, which is basically aortic valve chordae, which are nothing but embryonic remnants, but then more recently have been recognized to cause tenting of the valve and also causing malcoaptation and aortic insufficiency as well. All right, now a quick task for all of you. I think, please open your phone and join this menti.com. It's a quick, all you need to type in is just the code shown on the screen, which is 52063917. In the slideshow for a second here. All right, I'm going to ask you this question. How long do you think we've known aortic stenosis for? Is it 50 years, 100 years? I think there's a little delay. It's not coming through. I'm sure you all guessed it. It's almost 300 years, actually. So it was first described in 1600s by the Frenchman Lazare Riviere, who called it ossified and united so closely that the end of the little finger cannot be introduced. So way to go, right? So why are we talking about it in 2024 though, right? So it's the most common valvular heart disease. It's still the most symptomatic valve disease, most treatable valve disease, and also almost 20% of older Americans are going to have aortic stenosis, right? So very important. The evolution of aortic stenosis treatment is amazing, right? So if you think about it, the first SAVR was done in 1960s with a caged ball prosthesis, to valvuloplasties in 1980s, to the TAVRs in 2000s, right? And now in 2024, we have these many number of options. So truly amazing evolution. How can we not talk about this image, right? So there are a few images in medicine which are called iconic images, and I think we can't have an aortic stenosis talk without this image. This was actually the classic paper by Ross and Braunwald in 1968, which was actually the first one to demonstrate data in symptomatic aortic stenosis. And I'm sure all of you in the room know that after the onset of angina, the survival is usually 5 years, and then after syncope is 3 years, and after heart failure is actually 2 years. And even in 2024, symptoms remain the key element in the assessment of aortic stenosis and decision making, right? And this multi-center trial in 2023 is actually by far the largest one, which included a large number of patients. And if you see, any degree of aortic stenosis actually was associated with increased mortality. And that again highlights the need for earlier diagnosis, closer follow-up, and potentially earlier intervention as well. Again, I think looking beyond the valve, right? We are reaching the phase where we are not just concerned about the valve. What about the cardiac damage as well? Very important. Are we really okay waiting until the mean hits 40, right? And this amazing editorial by Dr. Little highlights actually the need to look beyond the valve and considering the cardiac damage into decision making and prognostication, right? So actually they grouped it very nicely as group 0 with isolated aortic valve stenosis only. And group 1 is actually LV involvement with either any type of LVH, LV systolic dysfunction, or diastolic dysfunction. And stage 2 is when you start seeing LA dilation actually with AFib and other associated LA pathology. And group 3 is where you start seeing RV changes, right? When you see more than moderate TR with systolic PA pressures in more than 60s. And group 4 is actually when you start seeing RV dysfunction, right? And actually, if more than one criteria is present, then they are identified as the worst stage. And the stage of cardiac damage actually was independently associated with mortality despite the valve being fixed, right? All that shows that it's not an isolated valvular abnormality anymore. All right, I think let's get into the meat, or I'm a vegetarian, so let's say protein of the discussion, right? So I can either let you pick or I'll pick a case. All right, let's just start with a simple one. I know we don't have too much time today. All right, let's see. I'm sure all of you can see the valve, right? Even from a distance, you know that the valve is pretty calcified and thickened, right? And I'll actually simplify the numbers for you. So VTI of 2.2, LVOT dimension of 2.2, VTI of 23.6. I know you need to use the calculator. I think most of them are choosing severe. Oh, there you go. Well, I think all of you chose the right answer, which is the severe aortic stenosis, right? And obviously, if you look at the valve area too, it's pretty classic, like severe aortic stenosis. Let's look at this case too now. So mild or severe or data incorrect or not sure? Not sure if this is working, but I'm sure most of you have chosen the right answer. Well, let me give you the valve area is 0.6. Right? Any of the fellows or sonographers, what do you think? Is it really severe? Right? What do you think is the problem here? So look at the size of the patient, right? So it's a 66-year-old guy with a height of 5'10" and a weight of 220 with a BSA of 2.4. An LVOT here of 1.8 is actually underestimating the LVOT, right? So if you actually correct the LVOT to the right dimension, to 2.3, which seems to be more appropriate in this patient, right? If you recalculate the numbers, it's actually moderate aortic stenosis, right? And actually, if you pay attention to the 2D images too, you see that the valve has a decent opening. And another clue, if you see, the peak CW is still 3.7 with a relatively early peaking jet, right? So remember, for the sonographers in the room who do an amazing job in getting all these done for us, always remember, LVOT measurement plays a very crucial role in assessment of aortic stenosis. Let's look at this case now. What do you think about this? I'll say takers for mild. Any takers for mild aortic stenosis? No? How about moderate? Right? How about severe? How about cannot tell?
Cannot tell.
Yeah, I think I'll go with Dr. Zogby. Why? Exactly, right? So very important to recognize this as well. So definitely, so if you just put a better aligned Doppler, you see the peak velocity was actually 5, right? So important, learning point for this is always when in doubt, go back and reassess your images. Make sure that the Doppler is aligned. And also for all the sonographers in the room, I'm sure you all use the dedicated small dual crystal or the PDOF probe to make sure that we are getting the peak velocities right, especially when you're using the right suprasternal, right parasternal, or the suprasternal windows. And one quick point here, especially for our fellows who are taking the boards, again, remember they can actually give you these blind Doppler data in the boards and ask you to find out what's the pathology, right? So if they do give you a 2D picture on the top, take clues from that so you know where the sample volume is. Timing from the EKG, right? Always important to know if it's a systolic event or a diastolic event. Look at the inflow pattern and velocities on top of the curve, right? If they are showing a peak velocity under the baseline, then look at what's happening above the baseline. If you know the tricuspid inflow velocities are relatively lower when compared to mitral, just because the tricuspid annulus is bigger, so you know the lesion is going to be something tricuspid related. And the most important clue is actually the duration of the flow, right? Is it happening throughout the systole or is it happening during the systolic ejection flow, right? And look for opening and closing clicks in mechanical valves. If they do give you prominent clicks, then obviously they're giving you a clue on mechanical valve. And look at peak velocity, right? It has to make physiological sense. Is it an MR jet or is it an AS jet? And look for the shape of the jet. Definitely very, very important clue, right? You have the parabolic ones and then you have the late peaking ones in HOPM. All right, I think we went through most of the crucial examples, but again we have a lot to cover. But again, I think our focus is going to be mainly on the calcific trileaflet aortic stenosis. Again, let's start with talking about the classic paper by none other than Dr. Zogby and Dr. Q, which demonstrated the key concept of continuity equation based on the principle of conservation of mass. So as we all know, it's basically very dependent on accurate measurement of LVOT and spectral Doppler data, both across the LVOT and aortic valve, right? So remember, what is more important in LVOT, guys, right? So always make sure it's zoomed in view, right? And you're measuring it at 0.5 to 1 centimeter from the valve orifice. And also make sure you're putting the measurement parallel to the flow, right? Or parallel to the beam, basically. And then remember, it's squared. So any small errors can actually double up, the error. And what is the next important step, right? So LVOT Doppler data, make sure you're putting a 3 to 5 mm sample volume in the, in the area of flow acceleration. And what's another important point is make sure you're tracing the modal velocity, right? You don't want to trace the hairs at the tip of the, Doppler pattern. Valve anatomy. I know it's not, I know the first thing we look at is obviously the visualization of the 2D opening of the valves, and you also see how thickened they are, how calcified they are, and most importantly, how many number of cusps they are, right? Direct planimetry of the valve is actually still, pretty valid, but although we need to acknowledge the limitations, there's a lot of calcium, there is shadowing, so it's sometimes hard on a transthoracic to actually really trace out the planimetry of the valve. And I think one important variant, we just talked about it, is the bicuspid. Again, I think it's very unique just from its genetic and metabolic profile itself. So I think it deserves a separate talk in itself. So I think we'll skip that for today's talk. And one other important concept, I think, which also needs a completely, an entire talk is this one, right? There are lots and lots of patients with HOCM and aortic stenosis. And what's more important in these patients is that you can't apply all the typical, Doppler patterns and equations, because if the proximal velocity is more than 1.5, you can't use the simplified equations. This one here, another important, I think every board will have this question, is they give you a normally opening aortic valve, but they give you peak velocities across the aortic valve to be high, and that kind of is an indirect clue of subaortic membrane. So let's quickly move on to jet characteristics, right? And what are the other alternative measures and basic grading criteria? One important point I really want to make is that systemic hypertension is very important, right? It poses a secondary pressure overload on the left ventricle, and it can actually lower the transaortic pressure and flow across. So always, whenever you're doing any aortic stenosis calculation, make sure the patient is normotensive. I think this is the most crucial part, right, of any assessment, is definitely the CW, or the peak velocity and mean gradients. Thankfully, the mean gradients are obtained by averaging the mean instantaneous gradients through the cycle, which the computer does for us, right? And again, we just talked about the Bernoulli's equation, right? Most of the cases, they should be good, except for cases where the proximal velocity is more than 1.5, or if the aortic velocity is less than 3, especially in patients who are congenital aortic stenosis. When the aortic size is smaller, then you need to take into account the other factors. And I think this is an ode, I think as Dr. Zogby mentions, it's the mother of all Dopplers, right? So this is one of the most favorite Doppler pattern, where you see actually as the severity progresses, the shape of the jet changes from triangular early peaking to more parabolic late peaking jet. Really an amazing, Doppler to, see, I should say. And this one, I think this table, every one of us in the room have it in their neurons, like, right? Everybody, even in your sleep, I'm sure you know more than 4 and more than 40 is severe. Again, one thing is calculated valve area of less than 1 is severe, and there are exceptions, which we'll talk about in a little bit. And finally, the parameter which is very helpful in patients, when you want to normalize to body surface area, is basically the dimensionless index, right? Again, less than 0.25 is severe. And these are all in normal or high flow conditions when the stroke volume index is preserved. But remember, everything is about symptoms, right? So we know the ACC/AHA guidelines, which is stage A at risk, and stage B is progressive, with stage C of severe with asymptomatic, and D is symptomatic severe. And again, AVR is a class 1 recommendation for stage D1, C2, or C or D if there are other surgeries happening. So I'm sure all of you know about this as well. But let's talk about special considerations, right? So I think this is something we really want to learn today, I should say, and I'm sure all of you have encountered it in the lab routinely, but important to know, hey, when my gradients are really not aligning with my valve area, what do I do? So these are the most common pitfalls. What do we do first? Check for errors, right? So that's the first step you need to do, is to go back and remeasure your LVOT, make sure the sample volumes are correct, make sure the Doppler is aligned, and that will be the first step, right? And the second scenario is really the flow state. Is this really a normal flow state versus is this a high flow or low flow? And what is a high flow state, right? So we have seen this very often again in liver patients who have hyperdynamic cardiac output, valve area of more than 1, peak velocity is more than 4. But what's important is we know it's a high flow state, but we need to identify when it's reversible, right? Like, is it anemia which is causing this? Is this something a patient had a GI bleed and now their gradients are high and the gradients were normal, the day before? There's a secondary component going on. And then obviously once we have established all that, now we know that for sure the flow is low. then obviously we have the two variants, right? We have the classic low flow, low gradient, and then the paradoxical low flow, low gradient severe AS. So we talked about this already. Again, I want to reiterate the point that you always want to make sure the highest velocity jet is obtained and not the MR signal is not what we are measuring. So now once we established, right, low flow, low gradient severe AS, which is AVA of less than 1 and a mean of less than 40, and stroke volume index is less than 35, but now the EF is less than 50, right? What's the first step is basically going for dobutamine stress echo, right? In this one, we start with a 2.5 to 5, an incremental increase every 3 to 5 minutes to a max dose of 20. So before we go into the discussion, right, or let me show you, like, let's talk about what's the scenarios, right? So what can happen? So first option is this one, right? I want to simplify this for you guys. At any point, if the aortic valve area increases more than 1, then you know it's not severe, right? That's a pseudo-severe state. That's the first scenario. Let's simplify again. What is this scenario now? An increase in stroke volume by 20%, right? So that's the second scenario where you know that the contractile reserve is there. What's the third scenario? This is the most important one, right? At any point, if your peak velocity is more than 4, and as long as the valve area doesn't change, then you know it's severe, right? So I think if you keep it simple, understand the basics, it's easier to remember that. And then what's the worst case scenario? Worst case scenario is there's no contractile reserve, right? So then there's no, flow augmentation, and basically you reserve, other modalities after that. All right, let's quickly look at a case example here. So as you see, it's an 87-year-old male with CAD, status post-CABG, aortic stenosis, and EF in 30s with, other more comorbidities like every one of our patients. And you see it's a prominent murmur, and again, let's go into the details. So take a look at this. So I think you can all appreciate a little bit of improvement in the EF with dobutamine, right? Okay, so let me give you the numbers. So the stroke volume has increased from 16 to 23, and the VTI, and the stroke volume has increased from 45 to 66, which is approximately 30%. Right? What's more important is we hit the peak of 4. So what do you think is this? Severe, right? So this is a true severe. What about a second scenario? VTI is gone from 12 to 20, and the peak is now 3 with a valve area of 1.4. What do you think is this? Pseudo, yeah, right? So I think you all, already got the, low flow, low gradient aortic stenosis, but what about a normal EF, right? In this case, everything is the same. The valve area is still less than 1, mean is less than 40, but now the EF is actually preserved. And I think, it is described as a conundrum. And again, as you see, low flow is low flow, right? No matter what the reason is. Like, it could be severe MR, where the flow is actually going in the opposite direction. It could be an intrinsically small LV, so the stroke volume is low. Or it could be AFib, it could be RV failure. No matter what the reason, you need to look at the big picture, right? And I think this is really an amazing editorial, which actually has some valuable insights on this topic by Dr. Zogby, and I think it's an amazing read. And I think the bottom line is trust, but verify. All right, let's look at this example. So we have a 90-year-old, smaller hypertrophied ventricle, peak velocity is 3.5, and calculated valve area of 0.59, right? Again, you want to make sure, so what's the first step, right? Again, you want to go back and measure and make sure that all the calculations are correct. And once you know it is established, then you go through the next steps, right? So let's take a quick look. So what are we finally talking about is integrating everything into the big picture, right? So obviously first is you want to establish the gradients and the valve area, right? And make sure that there is no high flow status. And like we just talked about, if it is high flow, then you obviously exclude reversible causes. Then the next option is to really establish the flow rate, right? Is it normal flow or low flow? And once you know if it's normal flow or low flow, and if it's low flow, obviously you go through DSE, right? And if there is flow reserve, you assess it to be true severe versus pseudo severe, Versus no flow reserve, or if you're not sure, then you go to the integrated approach, which is basically this. I know it's a lot of numbers in there, but the bottom line is, first of all, you want to make measurement error changes, right? Next is symptoms. Next is make sure that the systemic blood pressure is controlled, right? We just talked about that. And then the last thing, obviously, if you're not sure, you have RCT, to help us out, right? And I think the aortic valve calcium by CT is crucial here. I don't want to steal the thunder from Dr. Nabi, but just quick recap of the numbers, right? Women is 1,300 and men is 2,000. I think this is another number which we really want to remember. And again, as you see, it's very relevant, right? So if you see low aortic valve calcium score versus high aortic valve calcium score, it's an important thing to identify. Another important tool, is myocardial strain. I know half of the room is going to be divided into two if we talk about this. But again, there is data. There is data showing that actually, a GLS cutoff of 14.7% in this study, which was actually a meta-analysis of more than 1,000 patients, showed that actually 14.7% cutoff predicted survival at 2 and 4 years. They showed that beyond the valve, actually, low GLS predicts poor survival. And again, concept of aortic stenosis and amyloid is another important take-home point, right? I think the more and more it's being recognized that the low flow, low gradient preserved EF is in fact actually underlying amyloid. And there is also concept of amyloid infiltration of the valvular leaflets, which actually causes faster progression in these patients. And as you see, I think there's a lot of data coming out on that as well. How can we not talk about diastolic dysfunction, right? Partners in crime with aortic stenosis. And I think it's another predictor of clinical outcomes in aortic stenosis. This study again showed that actually a lot of patients with aortic stenosis have underlying LV pathology, right? If you look, majority of them have grade 1 diastolic dysfunction. And they also showed that grade 2 and 3 diastolic patterns actually persisted even after fixing the valve. And they actually did studies up to 12 months after the valve AVR was done, and they showed that the diastolic dysfunction persisted, causing high mortality as well. And the future is exciting, and I think there is artificial intelligence and machine learning in aortic stenosis, which again, I think is mainly going to help us with early diagnosis and early treatment in these patients. Quick summary, I should say, always echo first. Echo Doppler remains the first line modality for assessment of AS. Attention to details, very crucial. And integration of findings is pertinent, right? Always remember symptoms, 2D findings, and Doppler findings. Sorry, Dr. Navi, I had to do that. All right. And for the online audience, please reserve your questions. We are still on, right after the talk, we can take all your questions. Thank you so much. Payback.
I'm going to call it advanced imaging in aortic stenosis, and I'll show you why in a few seconds. So echo, yes, definitely first-line test, as Dr. Sherblu had shared with us, but there are challenges with echo, we all know. Image quality can be difficult in our obese patients. Sometimes you can't even tell what type of morphology the aortic valve is. Aortic LVOT diameter assessment is so important because you need that correct stroke volume in order to be able to accurately determine a valve area. You want to make sure your jets are parallel to the blood flow. Sometimes that can be difficult. You really can't completely visualize the aorta, and we know this is very important for those patients who have bicuspid valves. And it's not uncommon, as Dr. Sherblu had showed us, that you have discrepant results between gradients and valve area. So, of course, we have other techniques we can go to. We can go to a TEE and planimeter the valve, or as Dr. Sherblu also showed us, we can take them to the cath lab. Well, all of these are invasive, and obviously they come at some risk to our patients. Well, the good thing is we have some tests, non-invasive tests that we can perform that I hope can be very complementary to echo and fill in any missing pieces of information that may be important for the patient. So vast majority of my talk is going to be on CMR and how we use it to assess aortic stenosis. I will definitely talk about CT, and then 1 or 2 slides, I believe, on PET. So we know all the strengths of CMR. For the sake of time, I'm not going to go over it, but very good spatial and temporal resolution, the opportunity to do excellent tissue characterization, which will allow us to assess the myocardium, and then, of course, the ability to do flows, just like echo. Now, when it comes to the assessment of aortic stenosis, really it is no different than what happens in the echo lab. When I'm reading an MRI, first thing I'm thinking, okay, what kind of valve is this? What kind of morphology is the valve? And is it a case of aortic stenosis? Is that what the diagnosis is? The next thing that I'm doing is then I'm trying to grade the severity of the aortic stenosis, and I'm doing that in the MRI lab by planimetering an aortic valve and also looking at the peak antegrade velocity. More and more we've heard that aortic stenosis is a global disease. So the next thing I want to do is look at the other cardiac chambers and see what other chambers or portions of the heart may be involved. And this is where we look at volumes, mass, function, atrial size, PA size, all those other things. And then 2 things that I think that are unique to CMR, which can really fill in some important pieces of information about the pathophysiology of this disease, is the ability to look at tissue characterization and look at fibrosis, whether it's interstitial replacement, and also to completely evaluate the aorta, which becomes very important even when it comes to the therapy of the disease, which is often a TAVR. So here is an example. This is 4 different types of valve morphology. All we're doing is we're taking our long axis slices, we're creating an en face view of the aortic valve, and you can see with what clarity we can see the aortic valve, and it's very easy for us to determine what kind of valve the patient has. And these are 4 nice examples on the screen for you. Once we move on that this patient does have aortic stenosis and we know the type of valve they have, the next thing we want to do is determine how severe the aortic stenosis is. And this is again where I'll create a stack of short axis en face views of this aortic valve using my long axis views. And we're just going to directly visualize the anatomical orifice opening. And the way we do this to figure out how severe the valve is we will actually planimeter or trace the area on each of those slice locations. And the actual planimeter valve area is the smallest maximal systolic opening that you find at the leaflet tips. So just following a few simple rules, you can see that I can very quickly derive a valve area that is completely independent of flow. How does this relate to TEE, another anatomical test? You can see that in these 2 studies, and CT also, in these 2 studies, it correlates the planimetered valve area that you get with CMR correlates very nicely with this what you get by TEE or by CT. Now, one important thing to know about this is that the valve area that we quote to you from the CMR lab is an anatomical orifice area. This is very different from the valve area you're used to hearing about in the echo lab. That's a more physiological variable that is based on the continuity equation. And it is just slightly downstream of the stenotic orifice and where the flow actually converges a little bit. So what I'll be showing you in the next slide is that the anatomical valve area is actually just slightly larger than what you get by the continuity equation. And this is a table where they looked at a bunch of studies comparing planimetered anatomical valve areas with physiological valve areas obtained by the continuity equation. And the difference is that the planimetered valve area is larger by 10%. So on the order of 0.1 centimeters squared, plus minus something centimeters squared. Now, what's another important thing to know is that really there is no prognostic information based on planimetered valve areas as to patient outcome. All of that data comes from echo and from continuity equation. But we do report a valve area to you, and I think it's important for you as the physician who read these CMR reports to know that if we give you a planimetered valve area less than 1, remember the planimetered valve area is slightly larger than the effective orifice area. This really is a very strong argument that your patient has severe aortic stenosis. So the number is the same as the echo, but in general, just a little bit larger. How can planimetry help us? So I think a very challenging case was also mentioned by Dr. Shrublu is those cases that have obstructive hypertrophic cardiomyopathy, and maybe you see a lot of calcification of the aortic valve and have some accompanying flow acceleration across the valve. So in this study, I hope you can appreciate that you have not only some systolic anterior motion of the mitral valve, you've got some flow acceleration in the LVOT, and then you have flow acceleration at the level of the aortic valve as well. And by echo, using the continuity equation, you really can't apply it in this case. So it can be very hard by echo to determine what the valve area is. You would have to rely on things like the pulmonic valve. Whereas with CMR is really a big advantage over here. And the reason is because you have flow acceleration in the LVOT. And your Bernoulli equation kind of falls apart if the velocity is greater than 1.5. So with CMR, it's very easy. I may not know what the exact velocity is in the LVOT, but I can planimeter the aortic valve. So in cases such as this, it can be very helpful in elucidating the severity of the AS. CMR, of course, along with velocities, can also be very helpful to determine flow. So I can determine a peak antegrade velocity. We use this with something called phase contrast CMR, which is our echo Doppler. And basically, in echo Doppler, you have to be parallel to the flow of blood. With CMR, we have to be perpendicular to the flow of blood. And so this is just an example that how I would determine the velocity going through this aortic valve. I would create a short axis of the valve at the point of maximal systolic velocity using my long axis images. And then I would prescribe different velocity encoding. And the velocity where there is no aliasing tells us the velocity, the actual peak antegrade velocity through the valve. So in this particular case, you see aliasing at 3 point, when the VENC was set, or this aliasing velocity was set at 375. You see aliasing, which is that black and white in the same image. This just tells you that the velocity is faster than this, and you've got some protons that are being assigned in the different phase. You go up to 4 meters per second, you still see that, but at 4.25, you can now see smooth laminar flow. So this would be, a patient with, whose velocities would go along with severe aortic stenosis. Now, how do these velocities correlate with echocardiography? In general, it is a very good correlation, as proposed by these 5 or 6 studies that you see on your screen. But I would like you to know that we do, in general, slightly underestimate. And the reason is, as you know, with spectral Doppler, you have a temporal resolution of 2 to 3 milliseconds. With CMR, we're looking at temporal resolutions of on the order of about 40 milliseconds. So there is going to, because of this lower temporal resolution, I may not really find the true peak velocity through the valve. So we underestimate. You have some partial voluming because all our slices have some thickness to it. And there can be errors with turbulent jets and things like, and I may not be perfectly perpendicular, just like you can't be perfectly parallel to the flow of blood. So for all of those reasons, if I still tell you the velocity is more than 4, again, this is a very strong argument that you have severe aortic stenosis present. Now, there's a lot of information, and hopefully we'll get into this more and more in our labs. You're going to hear a lot of 4D flow. It seems to be very accurate at quantifying flow. It's also been shown to be much more accurate when comparing to echo in determining peak velocities. So here's another challenging, actually I'll skip over this case. Here's another challenging case where I think CMR can be very beneficial. This is a patient who has mixed aortic valve disease where you have both aortic stenosis and aortic insufficiency. Now if you're in echocardiography, right, it's difficult to determine what the systemic stroke volume here is, because if you use the aortic valve, you're going to get that AI that's also going back as part of that equation, and therefore you will overestimate your valve area. So either with echo, you're going to end up having to use, probably your pulmonic flows, and that's if you can see the pulmonic diameter. So it can be difficult, needless to say. CMR, very simple. Again, if I just want to know the valve area, I can perimeter the valve area, and if I want to know what the degree of regurgitation is, I create a slice location, somewhere in the root, and I just measure the amount of blood that goes forward, and I measure the amount of blood going back. So in those kind of mixed cases, CMR can be very helpful. The other assessment into all of this is what is the effect. Now we've determined the morphology of the valve. We've seen how severe the valve is. What is the effect on the ventricle and the rest of the heart? And as you know, I'm not going to belabor this because this has been hit on in multiple talks. Really, MRI is the gold standard when it comes to volumes and function because there's no geometric assumptions. We're tracing from the base to the apex. And this ejection fraction, as you know, is a very important number because really, if you look at the guidelines when it comes to determining whether your patient should get surgery, it's either symptoms, which no imaging test tells you, and the next variable is ejection fraction. So it becomes very important to know an accurate ejection fraction in these cases. Now, the other thing CMR is also very good at is determining myocardial wall thickness. We have great clarity in visualizing the muscle, so we can make very accurate measurements, linear measurements of how thick the walls are. But on top of that, we can actually determine LV mass. And we do this by tracing the epicardial contour and then tracing the subendocardial contour. And the difference between those two volumes becomes your myocardial mass. Again, this is completely free of any geometric assumptions. By echo, we're creating we have some assumptions based into those formulas. And why this number is very important, because mass has independently prognostic of cardiovascular events. Now with CMR, we've learned a lot of very interesting things when we evaluate, when we're looking at mass. And so these are two slides I'm going to share with you which really give us some insight into this disease. Number one, if you just look at where it says valve area of 1 or 100 centimeters squared, you can see that if you have severe aortic stenosis, valve area less than 1, right? There is no really, the amount of hypertrophy a patient has or the amount of LV mass a patient has really is not predicted by the degree of severity of the aortic stenosis. So that tells you a couple of things. Number one, it tells you that there's a lot of other factors that go into play as to how different patients hypertrophy in the setting of aortic stenosis. Things that have been shown, and I'll show you some slides of that, are arterial hypertension, sex, and genetic polymorphisms, of course. And it may also show you why some people who have a valve area of 1 may have no symptoms and another patient is very, very symptomatic, because it might explain some of these heterogeneity of symptoms. The other thing CMR has shown very nicely is that the different types of remodeling that you can get in the ventricle. We're all used to the concentric hypertrophy, that these patients have. And in very late stages, we've seen the LV decompensation. But did you know that 27%, or let's say 30%, have an asymmetrical pattern of wall thickening? So maybe the anteroseptum will be will be a little bit thicker than the posterolateral wall. And as it turns out, this is a good amount of patients that will have this asymmetrical thickening, but it actually has prognostic significance. In this study, the patients who had this asymmetrical thickening had worse prognosis than those who had a more symmetrical pattern. CMR has also shown that men and women respond differently to pressure overload. Men tend to develop an increased LV mass, and along with that will develop replacement fibrosis. Women, on the other hand, will have more concentric remodeling and less likely to develop myocardial fibrosis. So very interesting how we, despite the same valve areas, men and women again behave differently. We discussed a lot already about how this is a global disease. So it's not only important to look at the myocardium, but you got to look at the left atrium. You have to look at the tricuspid valve, the right ventricle, because as we know, as more and more of these organs these chambers are involved by the aortic stenosis, the worse the prognosis of the disease. And guess what? CMR is a fantastic tool to be able to see the entire heart. Now, two things, I brought this slide up because I want to hit on the real strengths of CMR here, which are fibrosis assessment and of course aortic assessment. And this is a lot of new data and I think may become important in, within a few years. So first is, we know from pathological studies that if you biopsy everybody who had severe AS and went to the operating room, that those who have more fibrosis present in their hearts, they tended to have dilated ventricle, lower EFs, and their prognosis was a lot worse. So scar is never good, is my bottom line from this slide. Now, isn't it amazing? We have a tool that helps you see scar. We have two types of scar. We have the replacement fibrosis, which is seen by LGE. This is a very late scar that happens. It's completely irreversible. Once you get it, you're stuck with it for the rest of your life. And then there are other techniques called T1 mapping and ECV, which allow us to look at interstitial fibrosis. And this is also a form of fibrosis where the extracellular space is expanded, but this is a more diffuse pattern. It happens early, before replacement fibrosis, and it's a completely reversible phenomenon. So patients who go on to have valve replacements, I'll show you some slides, have been shown that there's been a reduction in their this component of the interstitial fibrosis. Now, yes, we have a tool that can look at scar so we can assess the health and the function of the myocardium, but know that GBCAs are required for this. So what are some common replacement fibrosis scars that we see? Here on the picture on the top left is a patient who has no scar. Then you have somebody who has a subendocardial scar, which looks very much like a myocardial infarction. And then you have this mid-wall fibrosis, which really can occur anywhere in the ventricle. And we see this all the time. It's actually pretty prevalent in the CMR lab. If you have a patient with AS who comes in, 50% of your patients will have some replacement fibrosis present. What does this replacement fibrosis mean? It actually means that those patients, when they compared them to patients who had no LGE present, these were sicker hearts. The hearts were bigger, larger in diastolic volumes, they had higher index mass, and they had lower ejection fractions. So it means intrinsically that there is damage to the ventricle, and we now believe that this decompensation that we're seeing to the ventricle occurs through this process of fibrosis. So, finding LGE, again, remember, is an irreversible process. It's common, and it is a marker that the ventricle has really suffered from the pressure overload it's been seeing. That same study then looked prognostically for patients out to 6 years. And you can see that no matter what type of scar you have, whether it's the infarct scar or the non-infarct, mid-wall scar that we see with aortic stenosis, very common. And prognosis, as again, with any time we see scar, is much worse than somebody who has no scar present. So, a very important finding, telling us that mortality risk following AVR appears to be governed by markers of myocardial function and health, which is really the accumulated myocardial scar burden. And why this becomes important is because there are now 2 studies out there, and hopefully we should see the results of these coming out soon, which look at and try to intervene on the ventricle earlier in aortic stenosis before you have decompensation of the ventricle. One is where you're looking at early TAVR. They're going to be randomized to early intervention or routine care. We're going to see the results of that. These are asymptomatic patients with severe AS, really trying to prevent that, scar from ever happening. And then there's the EVOLVE study where you're going to have patients who will have mid-wall fibrosis, and you're going to quickly go ahead and replace the valve versus follow the normal guideline criteria for when you should replace a valve. And we'll see the outcomes of these important studies. So here's another challenging case where CMR can be really helpful. As you know, with LGE, we can really assess different disease states in the myocardium. We know from this nice study that looked at patients undergoing TAVR that with PYP scanning, that 16% had underlying amyloidose, ATTR. And so, well, what a great technique. We have CMR, we've given them the gadolinium. Just based on their LGE pattern, you can there's a very excellent correlation with this kind of diffuse global subendocardial to transmural pattern of LGE that we see. It correlates has correlated extremely highly with positive PYP scans. It also turns out these patients who frequently have underlying ATTR have this low flow, low gradient phenotype. There's then, that was all the replacement fibrosis and infiltrative fibrosis that we talked about. Then there's also the interstitial fibrosis. These are done through techniques called T1 mapping and, calculating an ECV, which requires a hematocrit. But bottom line is you're assessing the extracellular matrix. And all I wanted to show with you is these are 2 studies that have looked at this. You can see that, and number one, not shown here, but in other studies, that it tracks very nicely with the severity of aortic stenosis, number one. And then number 2, anytime you have any type of fibrosis, even whether it's extracellular and definitely replacement fibrosis, you are already impacting mortality and cardiovascular outcomes. As the ECV, or the amount of extracellular space, is expanded by this interstitial fibrosis, your risk progressively increase. So now what we've learned about this technique, disease state, is kind of summarized in this slide. You have a condition where you have a healthy valve, myocardium. It has a very tight valve. You have a very high afterload. The muscle thickens, and according to Laplace's law, to decrease wall stress. But it can only do that for so much time. As the aortic stenosis worsens, unfortunately, now you start that you can only thicken so much, before you start knowing it, you don't have enough capillaries for the amount of muscle you have. You have ischemia starting to set in. Cells start dying. Fibrosis is happening, the interstitial fibrosis, and as cells die, replacement fibrosis happens. And if still this process is not terminated, you're going to go on to a failing ventricle. And this is just one slide. There's looked at a lot of CMR studies looking what happens to the heart when we replace the valve. What does the function improve? Does the thickness of the wall improve? What happens to the scar? And I hope this is just a nice pictorial that tells you these studies have all shown that once you've accumulated replacements to a scar, unfortunately that's with you for the rest of your life, and it will impact your prognosis. Everything else, such as your cellular mass, will decrease on the order of 30 to 40% by CMR, and your diffuse fibrosis is reversible and will decrease. And then finally, another power of CMR is if your patient has bicuspid valves, these patients have aortopathies, we can very accurately measure their root and the ascending aorta, and we do this on a day-to-day basis. Very accurate compared to CT without radiation. There's again a lot of interest with looking at the aorta and 4D flow, and then a lot of these are new variables that maybe we'll hear more about in the future. CMR can also be helpful when you've made the diagnosis of aortic stenosis severity, severe AS, that these patients may need a TAVR procedure. As you know, these patients require very careful planning to make sure they're eligible for the valve and their anatomy is eligible to be able to deliver the valve too. So CMR, just like CT, can really give you very great accurate measurements of the peripheral vasculature and the annulus and the root and everywhere else these valves are going through. And it's very useful in this population because, as you know, they're elderly. They may have allergies to iodine, which make a CT difficult, and they definitely often have renal impairment, and again, no issues with the GBCAs and renal dysfunction, whereas not the case with iodine. So now I'm going to transition to the next phase of my talk, which is looking at some of the other imaging advanced modalities. You know, what about CT? We've talked a lot about MRI, but we heard some from Dr. Cherubulu. You know, what about it? Now, one of the things I want to frame this is, it turns out in the literature that is published that there is 40% of cases, there's a discordance between gradients and valve area. And this is published in the literature. 40% is 30 to 40% is the number they quote. And the thought is that obviously there's a lot of complex interactions going on here. There's the ventricle, there's the valve, and then there's the systemic arterial compliance. These three things together will, you know, dictate all of this. Now, instead of giving somebody dobutamine and stressing them and having to watch an EKG and seeing what, you know, all these different Doppler profiles you have to see, wouldn't it be better to have some sort of test which is flow independent, reliable? If I do it and Dr. Shah does it, we'll get the same results. Inexpensive, doesn't cost you anything, and is reproducible. And it turns out simply calculating an aortic valve calcium score could fit this test bill for this. And this is just an example. So we put the patient, we scan them according to the protocol you see on the right-hand side, and we are able to see, you know, anything more than 130 Hounsfield units are color-coded, and we're able to actually visualize the aortic valve calcium and actually quantitate the degree of calcium that's present. And in the guidelines, this has actually really strong data behind it. There has been 2 very large international registries looking at its diagnostic performance against echocardiography. And those numbers that Dr. Cherubulu mentioned, 1,300 for women, 2,000 for men, you can see exceptionally high positive predictive and negative predictive values for determining severe aortic stenosis. So it is a very good diagnostic tool. And at the same time, there is prognostic information as well, data out there as well. You can see patients here who have severe aortic valve calcium scores, be it men or women, in this dashed green line. They have, you know, a significantly different event survival compared to patients who are in the normal values of valve calcium. And because of this, because of its diagnostic and prognostic, it is now a class 2 indication in the guidelines for patients with suspected low flow, low gradient severe AS with either normal or reduced ejection fraction. So I personally think it should go before dobutamine echo, especially in the low EF ones, because you have nothing to lose. If the number is exceptionally high, and we've seen very, very high numbers, you know that if not today, within a few months, this patient is coming back to you with severe aortic stenosis. So, you know, I think for in these low flow, low gradient situations, you know, definitely consider a non-contrast scan. What about CTA? What if we actually gave contrast? Now, we've discussed already with MRI, so I'm not going to, you know, labor that. But CT really is a gold standard when it came to, you know, assessing the eligibility for TAVR valves. It tells you everything about the anatomy, peripheral vasculature, aorta, root, all the measurements that you need, and you see us do that all the time in the lab. And if you need, it even tells you information about the coronaries. So very, very effective test. But but where it's really now been a lot of new research is going, and is very, very kind of interesting, is the non-contrast scan shows you
the calcific portion of the aortic stenosis. But it turns out there's a good portion of the population which may not necessarily calcify. They actually have a lot more fibrosis, and this is frequently seen in women and those who have bicuspid valves. So CTA, it turns out, is a technique which has very high spatial resolution. You can see anatomy with great detail. And based on Hounsfield unit evaluation, you can actually separate fibrotic areas from calcific areas. And so a lot of people are looking at using CT, and the pictures on the right are an example of this. You can see the valve in short axis. The calcified area is the white, and then it's the green on the image right next to it to the right. And then the fibrotic areas are the ones that are shaded in red. So now you have a technique that potentially can show you both calcific and fibrotic regions of the valve. So just telling you, which may be important as we develop, new drugs that target the actual pathophysiology of this disease. CT, believe it or not, can also calculate ECV and global longitudinal strain, and that is upcoming stuff as well. And then the last portion of my talk really is just a slide that, a nuclear cardiology is also not to be left out. This is all research. This is not clinical in any ways. But, we have techniques now with 18 fluoride activity where you can look for, where it will predict where your calcification will progress. So in this particular case, you can see the baseline contrast CT on the right. You can see the degree of calcium that it has. You give this agent, which goes and gets attached to areas of inflammation, and you can see exactly where it lit up. And you can measure this with an SUV of how intense the level of uptake was. And then this contrast CT on the pictures on the right were done a year later, a little bit over a year later, and you can see now where the most intense activity predicted by this 18 fluoride PET tracer is where the new calcification was developing. So this is increasingly being used in clinical trials to assess the ability of potential novel treatments to reduce valve calcification and inflammation activity. So I will just summarize. I think aortic stenosis is really one of a very exciting talk. I want you all to know, yes, echo is number one, but there are a lot of other tools now that are available that can complement and add value to these patients. When it comes to diagnosis and management, diagnosis and severity assessment, know that you have cardiac MRI, know that you have calcium scoring that can be performed. Know that both CT and MR are excellent for assessing the aorta. And we have an excellent test with MRI to be able to assess the myocardium with a lot of other things that you can do. We'll often have to serially evaluate these patients, and really nothing beats echo for that. But when it comes time for actually the procedure to be done, know that MRI and CT, again, will be useful to you in your TAVR planning, and will also be helpful to you after the procedure. Because as you know, some of these patients have aortic insufficiency. It can be very hard to tell the degree of paravalvular aortic insufficiency. We have, and we can do a really good job with MRI. And even PET here has indications where these patients may develop endocarditis. It's a prosthetic valve. And we have a fantastic FDG lab here where you can actually diagnose infective endocarditis. So this is, when it comes to AS, I just want to leave you with the impression now is really a game of multimodality imaging. Dr. Shrublu will answer all questions.
Is there a microphone? Is there a microphone? This is a very nice, comprehensive review of really all modalities. I think that's very important. Technique is very important for echo. Just want to make sure that it makes sense, that the flow calculations make sense when you calculate the valve area. a point that you guys have raised, and I think I feel very strongly about, and that's what the guidelines say, is anatomic calcification measurement for assessment of severity is a last resort. And the reason why it's a last resort is if you look at the relation of calcifications to severity, it is not a tight relation. You mentioned that in women at times, calcifications are very low, yet somebody has severe aortic stenosis. At times you have a lot of calcifications, and the hemodynamic effect on that valve, although normal flow, is not as impressive. So what I'm saying to you, and I personally rarely refer unless I'm stuck. And what I mean I'm stuck is this is a low flow situation that I cannot change flow to understand whether the hemodynamic impact of this valve is important. Meaning there's no contractile reserve or the ventricle is very small. I can't do anything really to understand a different physiologic situation. And I'll revert to that, and you may revert also to anatomy, looking at it by different ways just to make sure that this is indeed the situation is. Now, at times it could be semantic, very close to severe. You can't go by just semantic and to take a look at the age. What are you trying to do? If somebody is 85, how much are you going to gain, right? If this is very close to severe aortic stenosis. But there is this appetite, just like anything else in life nowadays, that if I have a number, I'm going to go after this number and make a decision. I'm talking about calcifications. And you know very well also that it is very variable. It depends where the individual is drawing the region of interest for the calcifications of the aortic valve. And it could be encompassing, could be less encompassing, could be all over the place. So yes, use it if you're stuck. You use CT obviously for preparing of an intervention. Here we're trying to make a decision for an intervention, yes, no. So I feel very strongly about it because people say, particularly the interventionists, say, oh, I want to know the calcium score and go after it. Let me tell you, you could go wrong as much as. Why? Because the calcifications in calcific aortic stenosis are in the cusp. They're not like rheumatic, you know, restricting the opening. They can restrict it just because of bulkiness, right? And other things, but this is not where the stenosis resides.
Yeah, so first off, I want to thank both of you. I mean, I think you did a great job of taking us through from echo to more of the advanced imaging modalities. And I think the straightforward cases are straightforward. I think you highlight some of the complexities and the challenging cases. And I think I second what Dr. Zogby said, which is don't hang your hat just on numbers. And also the valve area of 1, gradient of 40, right? I mean, if it's 39, the patient's fine. I mean, you also look at the patient, look at the size of the patient, look at their symptoms and everything else. Let me kind of ask you guys to push you a little bit. Obviously, you've got in the challenging group right now, it seems to be the low flow severe AS group. And, you know, at least in my mind, one of the ways I think about it sometimes is maybe in the low EF patients where the contractile reserve information of flow augmentation may be much more useful versus in the preserved EF patients where I don't know if you're going to give dobutamine to somebody who's got an EF of 60, what are you going to do, right? So maybe the way you could dichotomize this is that the kind of the CT anatomic assessment may be more useful in the preserved EF patient population, whereas don't throw out the dobutamine echo in the low EF patient population, yes, where it can be useful to provide that contractile reserve information. Mm-hmm. I'd like to hear your thoughts on that.
Yeah, no, like you both mentioned, I think it is very, very important. And like Dr. Zogby is saying, I think reserving, just because we have the tools doesn't mean you need to utilize the tools all the time, right? So utilize it appropriately, and patient-specific is what's more important. And like Dr. Zogby and Dr. Shah are pointing it out, I think the most important one, which I feel like only when the echo is shortcoming, and especially when the patients don't have that contractile reserve, is when I think the next modality of choice is what, I mean, like you demonstrated, And same thing, Dr. Shah, like patients who have preserved EF, paradoxical low flow, I mean, it's more important to look at the big picture and find LV, pathology in those patients. But again, by no means DSC is utilized in those patients. So I think reserving, calcium score assessment for patients who don't have contractile reserve and in complex patients where you're thinking beyond the valve, I think is important.
Cover.
Yeah, thank you, Dr. Cherry. Thank you.